morning, everyone. I welcome everyone who is present for this webinar. So first and foremost, I would like to thank Dr. Raghu for accepting our invitation at the end minute and agreeing for this presentation. Thank you, Dr. Raghu. So let me introduce Dr. Raghu Ganesh. So he has done his master's in oral medicine and radiology, and presently he is associate professor, Department of Oral Medicine and Radiology, Meenakshi Ammal Dental College and Hospital, Chennai. Along with his academic pursuit, he is also a radiological safety officer at Meenakshi Ammal Dental College, CDE convener, IDA branch. He is a part-time consultant oral radiologist for CBCT private scan centers in Chennai, and his general and specialty-based private dental practice he has since 2003. So that's a lot of feathers in your hat, Dr. Raghu. And he's a life member of IDA, Indian Academy of Oral Medicine and Radiology, Indian Society of Dental Dermatology, and Telemedicine Society of India. And Dr. Raghu has presented numerous papers and posters in state, national, and international level conferences and many publications to his credit. He has also been organizing numerous CDE programs conducted by the Department of Oral Medicine and Radiology and by IDA Tiruvallur. It's utmost pleasure to welcome you, Dr. Raghu, to enhance our knowledge on the oral manifestations of and dental management consideration in COVID-19. So I welcome you, Dr. Raghu. The screen is over.
Thank you very much, ma'am, for the warm welcome. It's indeed an honor to present to this forum about oral manifestations of COVID-19 and the dental management considerations for such patients. I personally like to thank Dr. Purnima for the same. Can you please go to the next slide? Next slide. The learning objectives for today would be to understand what are the oral manifestations of COVID-19, and we will also try to make understand what are the guidelines that are being followed in dental setup at this current pandemic situation. And by the end of this webinar, you will be able to visualize what's being happening. Can Ashit put his mic on mute?
Just a second, sir.
Yeah, thank you. Before going into the presentation as such, it's customary to start with an introduction. COVID-19, the normal novel coronavirus disease 2019 is caused by SARS-CoV-2. And the incubation period is sometime between 2 to 14 days. It is very active in the initial stage, between 2 to 7 days. Coming to the next slide. Lung is the target organ, and it results in symptoms only because of the involvement of the tongue in most of the cases. Typically, the patients can come to us with mild symptoms like cold, cough, fever, breathlessness, or shortness of breath. In severe conditions, they report to us with pneumonia and severe respiratory distress. But we should never forget that there can also be atypical presentations of COVID-19. The patients may come to us with muscle pain, confusion. They can also have diarrhea and vomiting. The patient can have loss of taste sensation, and they can also have modified taste sensation, and they can perceive taste very different, and that can itself be the presenting complaint of some patients. Next slide. We'll first look into the oral manifestations. Oral symptoms can also be considered as initial symptoms of COVID-19, as like many other diseases that present in the oral cavity. We had been diagnosing diabetes mellitus for years together only based on the oral presentations, and we could be able to diagnose such patients. Definitely, oral cavity is the mirror of the body. Uh, the same way, COVID-19 can also have oral symptoms, and can these oral symptoms itself be an initial symptom in identifying these patients? Next slide. In moderate cases, in the mild and moderate cases, there are usually no oral presentations. The patient normally doesn't come to us with any oral presentations, but there have been a lot of reviews which had been done recently. Based on these reviews, more than 50% of the patients who came to who were affected by COVID had an altered taste sensation or modified taste sensation. They were not able to perceive the taste properly. This itself is being added as an early symptom according to CDC guidelines recently. The patient can present only with this, and we must be able to diagnose these patients in a dental setup. There can be oral unspecific ulcerations. There are many. Normally, we tend to see something like aphthous ulcer, traumatic ulcer. These kind of ulcerations can be seen in these patients also, which may not be attributable to some identifiable cause in this patient, and the patient will not give a history of previous ulcerations. The patient can also have decreased salivary secretion and dry mouth. There can be opportunistic fungal infections. The candida can present in the oral cavity as oral thrush. There can be multiple pinpoint yellowish ulcers on the dorsal surface of the tongue, almost mimicking recurrent oral herpes simplex virus infections. There can also be fixed drug eruptions in these individuals. There can be gingivitis in these individuals. Highly viscous saliva has been reported in few individuals, geographic tongue and petechiae. We will look into some of these pictures now. Next slide. This is called oral candidiasis. The common opportunistic pathogen, the Candida albicans that is there in the oral cavity, can form a pseudomembranous coat over the tongue and can result in a scrapable white patch, which is called candidiasis. Many of these patients present to us with this candidiasis. Next slide. Next. There will be this in between. Please change the in between slides. There can be altered. There can be non-specific ulcers which are not typical of any characteristic presentation. I cannot put it under aphthous because there is no erythematous halo. I don't call it as traumatic ulcer because I don't see trauma causing this. So this kind of an unspecific ulcer can be there. Next. Next. This is called geographic tongue. There will be raised white patches around a depapulated area. This gives an appearance like a map. That is why it is typically called geographic tongue. How we see in a globe, the same kind of a presentation is there in the oral cavity. That is why it has got the name geographic tongue. It has also got some other names as erythema migrans, geographicanus. Okay, this can also be presented in these patients. These patients can come to us with this symptom. Next. Next. There can be some petechiae, multiple red spots, small red spots, some ulcerations that are there in the oral cavity. Next. Patients who had already recovered from COVID-19 also have been found to have these symptoms like xerostomia, decreased salivary secretion. Sometimes they give a complaint of facial pain, altered taste altered taste sensations. There can also be problem in smell. Olfactory dysfunction can also be there in these individuals. These patients, even if had not been tested positive, and if they give us this kind of complaints, and there is a history of their contact with some known COVID positive patient, we can think in terms of these patients having been infected by COVID-19 already. Next slide. On trying to understand why these oral lesions occur in COVID-19 patients, this could either be a cause of direct viral invasion causing these manifestations and thereby presenting as their features, or because of the result of systemic deterioration that is happening in these individuals because of a compromised immunity, and thereby the opportunistic pathogens trying to manifest and present their symptoms in the oral cavity. These oral lesions can also be because of adverse drug reactions that have been administered in these patients. These drugs that have been given in these patients could cause that. A possible mechanism could be only this. It has been extensively reviewed, and they had clearly said the oral tissues, specifically the salivary glands and the tongue, they have high degree of ACE2 expression. This SARS-CoV-2 has got a binding to ACE2, and that is how it is causing the disease in the individual. Thereby, because there is ACE2 expression in these oral tissues also, we see these oral lesions, and COVID can be presenting as oral manifestations alone. One more reason is the presence of an enzyme called furin that facilitates the cellular entry of the coronavirus 2 in these individuals. Next slide. Coming to the dental management considerations of COVID-19. Now, next slide. We will just look into the dental management. This is the second part. Whenever a dental patient gets into a dental clinic, initially, no dental problem gets solved without getting treated by a dentist. That is the fact as such. But at this point of time, because of the COVID pandemic, we have also got into telescreening. We try to do telescreening first and do a thorough evaluation related to COVID, and we try to get them answer all the questions related to COVID and try to assess if the patient is having a high risk or low risk. Depending on the risk, we go ahead and proceed with the treatment for these patients. We also try to understand what is the care that patient requires. Is it an elective care? If it is an elective care, we can very well postpone and call the patient later for a treatment. Emergency cares should definitely be intervened as immediately as possible. This may even include life-saving intervention, like say, the patient can have a big cellulitis, will not be able to breathe properly, it may be choking, and he may need an treatment in the dental clinic. The patient can have an uncontrolled bleeding in the mouth. Sometimes there can be trauma of facial bones causing airway obstruction, and these patients cannot be denied dental treatment and should be taken for treatment as early as possible. The emergency care should properly be provided to them. Urgent care or which really require treatment, but it is not a real emergency, we can little bit assess properly and take these patients, and we should try to reduce the pain in these patients. Especially pulpitis pain, most of the time doesn't get resolved with medications. We may need to administer antibiotics in these patients. The pericoronitis should somehow be cleaned, at least by hand scaling, and the patient should be relieved of the problem. Abscesses should be drained if required, and the patient should really be managed properly for urgent care. Coming to the next slide. Teledentistry at least helps us in trying to understand what the patient's problem is. Our main intention at this point of time is to have as minimal contact time with the patient as possible. If we can assess the existing condition in the patient before they come into the dental clinic, we'll be able to plan the treatment ahead, and we'll be able to go ahead with and proceed the treatment and send off the patient as early as possible. So these patients can be assessed, and we have to be really determine if the patient really needs treatment in the dental setting. For that, we can use all the possible digital facilities available as of now, like we can use WhatsApp videos, WhatsApp photos. We can also use the online meeting apps, and this is I find this really working very good. Without even seeing the patient directly, we are able to solve the problem and do a justification in playing our role. Next. In the dental reception area, as like any other hospital setup, we are supposed to have a hand wash or an alcohol-based hand rub having at least more than 60% of ethyl alcohol or isopropyl alcohol. For drying, it is better to use a hand dryer or a tissue paper that can be disposed for each patient. The disposables should be available through non-touch receptacles. Our intention is to prevent cross-contamination and the spread of infection. Temperature recording is mandatory. No, non-contact infrared thermometer can be used, and it should be used for every patient. All the patients who are all accompanied by the family members should also be assessed. The family members should also be assessed for the change in temperature, because they also come into dental clinic. We should ideally advise and avoid any accompanying person in the dental clinic, preferably. If the patient really needs help by somebody, you can let them in. Instructions to be given to the patient to wear a mask while waiting in the reception area, and we should also tell them clearly to maintain the respiratory hygiene, proper cough etiquette. They should be very careful and maintain a proper hygiene in the reception area. The screening questionnaire is a part of every dental visit, as like any general medical admission. Any history of fever or respiratory illness, including cough or difficulty or breathing, should be noted down. Any history of contact should be noted down. Any history of international travel should really be made a note of. Next slide. After getting the consent from the patient to see them in the dental clinic, there are standard forms that are available by Indian Dental Association, and we can make use of that to get consent from the patients. We should let them in the reception area. The social distancing should be properly followed. The distance between the chairs should be clearly maintained. At least 1 meter distance should be there. Ideally, we should try using a cleanable, cleansable, easily maintainable chairs, and we should avoid using sofa kind of chair setups. We should remove magazines, articles, toys, and any other objects that are difficult to disinfect. No cluttering at all. All it should totally be decluttered. Coming to the next slide. We can have a glass or a plastic barrier at the reception desk. We should encourage cashless or contactless payment methods. The number of patients in the reception area should be limited. We see to that only one patient is available at that particular time. We should stick on to the appointments and work only with the appointments. We can ask the patient alternatively to wait and wait in their vehicle and call them whenever we can call them whenever there is adequate space to accommodate them. The person accompanying the patient should always be limited to one at the maximum. In the dental reception area, it is recommended to use natural and mechanical ventilation using fans and exhaust. We should avoid usage of commercial split or centralized window or window air conditioners unless equipped with HEPA filters. The high efficiency particulate air filters are now becoming mandatory to be used in dental clinic, because they can help us in cleaning the air around the dental chair. HEPA has been recommended to be fixed over the ventilation systems in areas where negative pressure rooms are not possible. Ideal is to have a negative pressure rooms. Next. The high vacuum extraoral suction devices are really mandatory. The low vacuum suction does not really suck so effectively. High vacuum that is there in the dental chair can be utilized, or we can have an extraoral suction device that can be used. We can use a table fan behind the operator and let the air flow toward the patient and away from the doctor. This would be the easiest possible way to maintain ventilation in a dental clinic. A strong exhaust fan is placed to create unidirectional airflow away from the patient, so that the airflow is there from the non-contaminated area to the contaminated area, away to the exterior. We should always avoid using ceiling fan, because that can rotate the aerosols within the dental clinic and can result in infection later. Use of indoor cleaning system equipped with HEPA and UV light is being recommended by all the guidelines that have been proposed by different people. Many people have proposed the guidelines, but most of them clearly say indoor cleaning system is very, very important, equipped with the HEPA filter. Ultraviolet light is very useful in cleaning the upper airway. as the particles drop down and settle down, it is easy to clean with the cleaning system. Window or split air conditioner should be frequently serviced and the filter should be regularly cleaned. Electrostatic air conditioner filters commercially available by 3M can be used and can help us in a little bit of clean environment maintenance. Next slide. The problem with dentistry is the aerosol production. There is no clear data yet if the aerosol produced in dentistry is similar to that is produced by while we intubate a patient or when the patient coughs out. It is not similar to that because the aerosol, the water that is used in aerosol is a clean water, sterile, mixed with sodium hypochlorite, very minute quantity of sodium hypochlorite. So it is relatively safer when compared to the direct saliva that is emitting from the patient. So the aerosol is of concern to us. High-speed saliva ejectors can be utilized regularly. We can have an anti-retraction valve because whenever the handpieces are used, there can be a reverse suction of saliva into the handpiece and there can be a cross-infection. So to avoid that, we can have an air retraction valve having handpieces, or there are adapters that are available that can be used to use the regular handpieces with these adapters. Rubber dam plays a prominent role. Rubber dam is used to isolate and see only the tooth, and we will be able to cover the rest of the oral cavity by the rubber dam so that we don't get direct exposure to the oropharyngeal secretion and the patient doesn't infect even if he is positive. Next. Before the patient is made to made to open the mouth, we clearly instruct them to start mouthwash as soon as he opens he removes his mask. The mouthwash that is normally preferred is 1% hydrogen peroxide as recommended by IDA. It is going to be very difficult to gargle with hydrogen peroxide. The patient don't really feel very comfortable with the hydrogen peroxide, though it is the standard of care. I would prefer giving 0.2% povidone iodine, which is a little more comfortable when compared to hydrogen peroxide. There is no definite evidence to support the use of chlorhexidine, which is also used as a mouthwash. There are emerging evidences which recommends chlorhexidine instead of povidone iodine for its substantivity. It stays in the oral cavity for a longer time and produces desired effect rather than the povidone iodine, which produces only an effect for a shorter period of time. There is still a research going on this. We should really understand that there is a lot of research still going on about this COVID-19, and there can be a lot of changes which can be implemented in the near future. What are being discussed are based on the current recommendations and guidelines. This can get modified as and when more of this disease is understood. Next slide. Personal protective equipment becomes the standard of care. There is no way we can treat a dental patient without removing the mask and without by staying at a distance of 1 meter. The normal protocol for anybody to get not infected by COVID is to ask the patient to wear a mask, ask everybody to wear mask, and to stay away from them. This too is not possible in a dental setting because we have got to work into the oral cavity. So the basic personal protective equipment becomes mandatory to be used in every patient care. We should go ahead with the use of goggles, face shield, mask, gloves, coverall gowns. Coverall or gowns are mandatory to be used in any dental setting. Head cover should be ideally used. Shoe cover should also be used. Barrier protections wherever possible in the light handles, chair switches, headrest. We always try to implement that, and we should always use barrier protection wherever applicable and possible. Coming to the next slide. The surfaces should be properly maintained clean. Use sterilizable trays whenever possible. We also protect this with disposable coverings for barrier protection. Between clinical sessions, work surface should be cleaned. If visible blood is there, sodium hypochlorite should ideally be used. Instrument processing should be meticulously carried out. There should be pre-soaking of instruments properly in the soap water, because this soap though this COVID is a very dangerous, the soap kills most of these viruses. So it is going to be useful for us. So it should be soaked in soap for some time, and then it should be cleaned, pre-cleaning with brush nicely. It should be cleaned, and then it should be properly packed. It should be sterilized, and then the sterilization should be properly monitored by using spores. The process instrument should be handled properly and should be stored in ultraviolet chamber until being used. Next. Goggles and face shield become mandatory. It helps us in avoiding of contact of virus through the mucous membranes of the eye or the nose or the mouth via touching, sneezing, or of the infected patient, or generated aerosol that is produced during the dental procedures. It also helps us in providing good seal with the skin of the face. It covers the eyes and surrounding areas and even accommodates for prescription glasses with indirect vent to prevent antifogging and be resistant to scratches. Though ideally these are all recommended, we are really finding it very hard to work with these goggles and face shield. We are not able to provide the care that we had been providing earlier. The same care is not possible with these face shield. That is why we try avoiding the patients with elective care at this point of time until we come to a more clear, better picture. This goggles and face shield should be mandatory for any patient, to see any patient. Next slide. The patients only wearing a mask and head cap is not sufficient. I should definitely be covered. This is not good. The second one is okay because it covers eyes and mouth, but that is okay for a non-aerosol generating procedures because there is not going to be much of splatter. But ideally the head should also have been covered. The third is good and fine. But if aerosol generating procedures, even that is not enough. The fourth is okay, but for an aerosol generating procedure, even that is not sufficient. Next slide. These are the different PPE that I tried and I personally used. I am very comfortable with the surgical gown because it is a little breathable and it is washable, easily maintainable. I produce a little less of biomedical waste. But also I protect myself, so I prefer using this surgical gowns, washable. If there is an extensive aerosol procedure and if we do a lot of cutting on tooth preparation, ideally we should go for good PPEs covering the entire body. Next slide. We should always use mask. Earlier there had been days when dentists had seen patients without using mask. With the awareness of HIV and hepatitis, masks came into practice and gloves had started being gloves are being used by all the doctors now, dentists now. So now this PPE will also become a new norm in the future. Without mask we are not supposed to see any patients. Basic requirement is a triple layered medical mask. Cloth mask is not going to help us. Cloth mask is okay if you are not seeing a patient and if you are taking rest in the clinic in between patients. Cloth mask is okay and you can use that, but not when you see a patient. A minimum requirement is triple layered medical mask. N95, N99, N100 respiratory mask are ideal to be used in the dental setup. Triple layered medical mask we had already discussed. It should be made of a non-woven material. We should have a nice nose piece. Without a nose piece, it doesn't fit into the nose properly. It should have a high filtering efficiency. Next. N95 is the minimal requirement for a dental clinic. It's a respiratory protective device with high filtration efficiency to airborne particles. They have high fluid resistance, and the duckbill or cup-shaped structure design is better because they do not collapse against the mouth as we keep talking to the patient, as we are communicating with the patient. So this is better than the cloth type of mask, cloth type N95 masks. Next. Filtration, ideally we should go for N95 at least. FFP1 and FFP2 doesn't serve the purpose. FFP3 and N99 are still the better. N100 is good. The only problem with N100 is they are being designed for industries, and the patient sometimes gets scared to see you with such a big device on your face. But they are good for a long time working in a dental clinic. Next. Valves are ideally not to be used because there is an air outlet happening from the patient to the environment and can result in an infection. If the patient is wearing a valved mask, you please ask it to be covered by a surgical mask. And as doctors, we are supposed to use only surgical mask, non-valved respirators. Next. Nitride gloves are preferred over latex gloves because they resist chemicals, including certain disinfectants such as chlorine. Because we are now the sodium hypochlorite has become a great necessary chemical in our practice. So we should ideally use nitrile gloves. If not available, non-powdered latex gloves are okay. Our outer gloves preferably reach mid forearm. We should have a minimum of 280 millimeter total length. Next. Next slide. Head cover is mandatory. Those using gowns should use a head cover for sure. It is basic necessity to fit the hair within the head cover. Next. Shoe covers are also ideal because we can avoid cross contamination, and the WHO even today says there is no real infection carried or spread through shoes, but it is ideal to prevent any cross infection. Earlier only in dental clinics we avoid the dental infection. We avoid the patients wearing shoes and sitting on the dental chair. So this should also be used whenever possible. Next. If there is somebody in the registration counter in the outside of the dental clinic, the table, please. Can I get the earlier slide? Yeah. If there is somebody waiting in the registration desk and he is a front office person, the triple layered mask is sufficient for that patient, and the patient can use only latex examination gloves because there is always physical distancing that can be employed there, and the registration desk counter person is relatively safe. The dentist or the assistant in the dental operatory, if we are doing only examination, 3-layered mask is now accepted as a minimal requirement, and protective eye wear or face shield should always be there, and the gloves by default becomes mandatory. So the eye should be covered, also the mouth should be covered. Moderate risk whenever there are non-aerosol procedures, but we are going to do some procedure in the patient like a tooth removal, we may need a N95 mask along with the previously mentioned requirements. When there is a high and very high risk procedures, we also need gloves, and we also need a coverall which can be disposed of. Aerosol generating procedures, we should be really safe and careful. Next. Coming to the sterilization part, the floor should be mopped with 1% sodium hypochlorite solution with a contact time of 10 minutes. Ideally, as like before, we should do a soap cleaning, a detergent cleaning before mopping with the sodium hypochlorite. The sodium hypochlorite should have at least a contact time of 10 minutes. We should use separate mops for the clinical area to avoid contamination to the regular area. Unidirectional mopping technique should be followed by mopping from inner to outer area, from the non-contaminated to the contaminated area. Ideally, the floor should be cleaned after every patient or after a major splash, or at least if we have 2-hour period, we should clean. Wash and disinfect the mop with clean water and 1% sodium hypochlorite, and leave it for sun drying for it to dry. Next. Rest of the surfaces can be cleaned with freshly prepared sodium hypochlorite. Disinfection should be done daily before starting work, after every procedures, and at the end of the each day. This has made dentistry a little more organized, and it takes a longer time nowadays to treat patients, but this has become the standard of care. Whenever there is a delicate electronic equipment, obviously sodium hypochlorite cannot be used, and we should go ahead using the alcohol based rub or spirit. Next. Next slide. After the patient leaves the operatory, the assistants collect all the instruments immediately. He rinses them in the running water to remove any organic matter, and cleans it as per the sterilization protocol. all the 3-in-1 syringes, water outlets, handpiece, water pipelines should be flushed with disinfectant solution at least for 30 to 40 seconds to prevent any cross contamination. The water containers should be removed. They should be washed thoroughly, and they should be infected with disinfected with 1% sodium hypochlorite, and either using clean cotton or a gauze piece, and then it should be filled with 0.01% sodium hypochlorite and attached back to the dental chair. Next slide, boss. Disinfect the dental chair along with the auxiliary parts. Everything should be cleaned and wiped and should be maintained very, very clean. The areas include the patient sitting areas all around. Wherever possible, barrier protection can be employed. Wherever not possible, it should be thoroughly cleaned and kept clean. Next slide. Hand pieces should be cleaned using a handpiece cleaning solution. There are specifically available for that. They should be ideally be cleaned, autoclaved whenever possible. Ideally, before changing, for every patient, it should be ideally autoclaved. Impressions should be thoroughly disinfected. Ideally, we can soak them in sodium hypochlorite solution for 10 minutes, and there are disinfectant sprays that are available commercially. For example, there is something called Dimenol alcohol sprays that can be sprayed on the cast and then should be given to the lab person so that there is no cross contamination. Next. Hand hygiene becomes mandatory. We should ideally follow hand hygiene. This has been discussed very much in detail, and everybody, every normal individual is now aware of that. Every layperson knows how to wash the hands. We should implement this properly before touching a patient, before touching any instrument, after touching a patient. We should ideally go ahead and clean their hand and keep and maintain it properly. Next slide. What do we do in case if we come across a suspected or a confirmed case of COVID-19 in a clinical setup? If the patient gives a symptoms typical of COVID-19, normally such a symptomatic patient would not report to a dental clinic with so much of a difficulty. Asymptomatic patients can report to dental clinics. The universal precaution says treat every patient as an infected patient. Consider them as infected patient. Follow all the possible protocols and prevent getting infected. So if at all we suspect a patient and you are seeing a confirmed patient, you should not do any clinical work for the patient. Defer the clinical treatments. You isolate the patient, report to the local authorities, and list out the patient's clinical status. The clinic should be thoroughly disinfected. The staff and the health worker who attended the patient can be quarantined. The quarantine time has now come down very much. It is not for 2 weeks now, but ideally should be quarantined for at least 2 or 3 days, and then we can go ahead and start seeing the patient again if the exposed persons do not show any symptoms. Next. In case as a dentist or a staff gets infected, or you suspect an infection in these patients, in dentists, we should stop working, and we should encourage the workers to employ to inform the employees and take leave. Isolate and refer to COVID care hospital. Quarantine the workers in contact with the suspected or confirmed cases. Share the details with the local health care workers at any time. It is our duty and moral responsibility to do this and be sure that nobody else is infected in our dental clinic, and we should make sure we do not spread the infection across the patients. Next. So I would like to summarize this by telling that the current CDC guidelines have now said it is good, and we can go ahead and start treating even the patients with non-urgent and non-emergency dental care if it is going to cause some kind of a discomfort or a problem in the patient. This cannot wait for long, because this is not going to end COVID. Definitely, we all together can work properly with proper protocols and win this situation and can have a high end over this. I'm done with the presentation. Thank you for this wonderful opportunity. I again would like to thank Dr. Purnima for this opportunity to address all of you. I'm ready to answer any of the questions. Please feel free to put forth the questions. Thank you, ma'am. Thank you, everybody.
Yeah, that's a wonderful presentation, Dr. Rabu. Ask you one question, since PTK, the candidiasis, everything is otherwise also very common. So I understand whenever a dental patient comes with PTK or geographic tongue or superimposed candidal infection, as we do in the medical practice, even the regular flu patients, they are screened now. Previously, flu was such a common
Yes, ma'am. Even asymptomatic patients nowadays
thing.
come
No
to
one
us
bothered
only with
about it.
flu-like symptoms.
But today, if someone gets flu, it's a big thing. So similarly, whenever lesion, so I guess whenever we encounter a patient with such lesions, it becomes mandatory to send them for a COVID test. Am I right, doctor?
Yes, ma'am. Practically, the COVID tests are now available. The antibody test strips are available. We can start using in dental clinic. They are allowed dentists to use it. It is available. Whenever we whenever we post a patient for a surgery for a longer duration of procedure, it is good to test and then take the patient, ma'am.
Yeah, thank you. Thank you so much,
Welcome, madam. It was a good
Dr.
opportunity
Rabu.
for me. Thank you for the opportunity.
After such a short notice, you made a wonderful attempt to enhance our knowledge on the oral manifestations.
Thank you, ma'am.
And I would like to thank the PU webinar team also, Mr. BJ Acharya and Mr. Jiten Kubani, for being very supportive and guiding us through this procedure. Thank you. And I personally would like to thank my department staff. Everyone was very supportive in organizing the webinar. So thank you, everyone. Have a good day.